about warfarin because it's the only one that's widely used in Ireland. So why do we anticoagulate? So the common indications, now this isn't comprehensive, there's weird and wonderful indications, but these are the common ones. So we're trying to prevent stroke and thrombosis in patients with atrial fibrillation, if it's appropriate for them, depending on their CHA2DS2-VASc score. Prevent stroke and thrombosis in patients with antiphospholipid syndrome and patients with a mechanical heart valve. To prevent VTE in patients after orthopedic surgery, and to treat DVT and PE in the first instance, and then to maintain anticoagulation if needed if it's a recurrent DVT or PE. And just to note that not all anticoagulants are licensed and indicated for all of the above conditions. So just run through each one very quickly. So apixaban, so factor Xa inhibitor, just indicates where it works in the clotting cascade. So used to prevent VTE in adult patients who have undergone elective hip or knee replacement surgery. So we're looking at 2.5 milligram twice a day, 32 to 38 days in patients with a hip replacement surgery, and for 10 to 14 days in patients with a knee replacement surgery. So the most common that I would see, I'm based on the stroke ward, so I would see it, is the prevention of stroke and systemic embolism in adult patients with non-valvular AF, with one or more of the risk factors listed there. So previous stroke or TIA, age more than or equal to 75 years, hypertension, diabetes, or symptomatic heart failure. So the recommended dose is 5 milligram twice a day. And the recommended dose of apixaban is 2.5 milligram twice a day in patients with non-valvular AF, and at least 2 of the following characteristics. So age 80 years or more, weighs 60 kilos or less, and serum creatinine, we use the micromole per litre, so serum creatinine more than or equal to 133 micromole per litre. There are separate criteria for reducing the dose in line with poor renal function, but I'll run through that on a later slide. And usually for this indication, the therapy should be continued long term. So treatment of DVT or PE and prevention of recurrent DVT and PE in adults. So recommended dose of apixaban for the treatment of acute DVT and treatment of PE is 10 milligram twice a day for the first 7 days, followed by 5 milligram twice a day thereafter. So the short duration of treatment for at least 3 months should be based on transient risk factors. So basically, if it's a provoked DVT or PE, you need to anticoagulate for at least 3 months. The recommended dose of apixaban for the prevention of recurrent DVT and PE is 2.5 milligram twice a day. You would only start the 2.5 milligram twice a day after the patient has had a full treatment dose of 5 milligram twice a day for at least 6 months. So renal impairment, this is comes back to what I was saying earlier about the you would reduce the dose of apixaban independent of the other risk factors, weight and age and things like that, in prevention of stroke and systemic embolism in atrial fibrillation in patients with a creatinine clearance of 15 to 29 mils per minute. So that's separate to the other criteria. And then for the prevention of VTE and elective hip or knee replacement surgery, for the treatment of DVT, treatment of PE, and prevention of those, apixaban is to be used with caution. No specific recommendations. It's just to be more cautious with it. So edoxaban, another factor Xa inhibitor, and like apixaban, is indicated in the prevention of stroke and systemic embolism with non-valvular AF and the same risk factors. So congestive heart failure, hypertension, age 75 or above, diabetes, prior stroke or TIA. It is also indicated in the treatment of DVT and PE, but you must have had 5 days of parenteral anticoagulant treatment first. You can't go straight in with edoxaban. You have to have 5 days of parenteral anticoagulant treatment first. And for the prevention of recurrent DVT or PE in adults. So that is just the dosing summary, just taken from the SPC. So the recommended dose is 60 milligram of edoxaban once a day. And the dose recommendations, the recommendations for the 30 milligram once a day is as outlined. So if they've got one or more of the following clinical factors, so renal impairment, if the creatinine clearance is between 15 and 50, so that is a much wider bracket than it was for apixaban in terms of reducing the dose. So it's just something to bear in mind. Low body weight, so again, we're looking at the 60 kilos or less. and PGP inhibitors, so cyclosporin, dronedarone, erythromycin, ketoconazole. If you meet any of those criteria or more than one of those criteria, you're looking at the 30 milligram of edoxaban once a day. So rivaroxaban, another factor 10A inhibitor, quite a wide range of licensed indications. So prophylaxis of VTE following knee replacement surgery, 10 milligram once a day for 2 weeks. Prevention of VTE following hip replacement surgery, 10 milligram once a day for 5 weeks. Treatment of DVT and PE, so we'd all be familiar with this one. Initially 15 milligram twice a day for 21 days with food. Then maintenance is 20 milligram once a day, again with food. Prophylaxis of recurrent DVT and PE. So 10 milligram once a day, again after completing at least 6 months of full anticoagulant treatment. However, if they're patients at high risk of recurrence, or they've had a previous recurrence with rivaroxaban 10, you can prescribe 20 milligram once a day long term. It depends on individual patient factors, the risk of bleeding, the risk of clotting, and those being weighed up against each other. So prophylaxis of stroke and systemic embolism in patients with AF, and again the same risk factors as previously, 20 milligram once a day to be taken with food. Newer indications for rivaroxaban in the lower dose. So prophylaxis of arthrothrombotic events following acute coronary syndrome with elevated cardiac biomarkers, either in combination with aspirin alone or in combination with aspirin and clopidogrel. So 2.5 milligram twice a day, and that's usually for 12 months. Prophylaxis of arthrothrombotic events in patients with coronary artery disease or symptomatic peripheral artery disease at high risk of ischemic events. And this is in combination with aspirin alone, is 2.5 milligram twice a day. So when we're looking at the renal impairment for rivaroxaban, when used for DVT or PE, following the first 21 days of treatment, so that's your 15 milligram twice a day for the 21 days, the usual dose of 20 milligram once a day can be given, but you can consider reducing to 15 milligram once a day if the creatinine clearance is between 15 and 49 mils per minute, and if the risk of bleeding outrisks the risk of recurrent DVT or PE. So again, it's very individual to individual patients. It has to be tailored. When using for prophylaxis of recurrent DVT or PE, so if the recommended dose is the 20 milligram once a day, so if they've already had a recurrence on the 10 milligram, or if they're at very high risk, you can consider reducing to 15 milligram once a day if the creatinine clearance is 15 to 49 mils per minute, and again if the risk of bleeding outweighs the risk of recurrent DVT or PE. And when used for prophylaxis of stroke or systemic embolism in patients with non-valvular AF, you do reduce to 15 milligram once a day if the creatinine clearance is 15 to 49 mils per minute. And again, the bracket, the range of creatinine clearance is wider for rivaroxaban than it is for apixaban. So it's just, again, something to bear in mind. So dabigatran, first DOAC on the market, and it is a thrombin inhibitor. So it works at a different part of the clotting cascade than the factor 10A inhibitors. So it is licensed for prevention of VTE and orthopedic surgery as well. So again, following elective knee or elective hip surgery, the maintenance dose, which is what you would tend to see in the community, would be 220 milligrams once a day. 10 days for knee replacement and 28 to 35 days for hip replacement. And you can see there, dose reduction is recommended if the creatinine clearance is between 30 and 50, if the patient is on verapamil, amiodarone, or quinidine, or if the patient is 75 or above, so at a higher risk of a bleed. And then we're looking at 150 milligram once a day. And again, the duration is the same. So 10 days for knee and 28 to 35 days for hip. Prevention of stroke and systemic embolism in atrial fibrillation, patients with one or more risk factors. So 150 milligram twice a day. And treatment of DVT or PE, and prevention of recurrent DVT and PE, again 150 milligram twice a day. And like edoxaban, a patient has to have been treated with a parenteral anticoagulant for at least 5 days. You can't go straight in with the dabigatran either. So a dose reduction is recommended if the patient is aged 80 or above, or if the patient is receiving concomitant verapamil. So then we're looking at 110 milligram twice a day. and when you can consider a dose reduction, but again, it comes down to individual patient, the risk and benefits. You can consider a dose reduction for a patient who is aged between 75 and 80 years of age, patients with moderate renal impairment, so creatinine clearance of 30 to 50, patients with gastritis, esophagitis, or GORD, because they would be at a higher risk of a GI bleed, and other patients with an increased risk of bleeding. So again, very patient specific. So the daily dose of dabigatran would be either 150 BD or 110 BD. So we're looking at it based on individual assessment of the risk of a clot versus the risk of bleeding. So it's very, very specific to individual patients and their history, if they've had a bleed before, if they've had a history of clotting. It's all very specific to the patient. So on to warfarin, vitamin K antagonist. So I have a few indications listed here, but warfarin can be used in a lot of different indications as well. So we're looking at prophylaxis of embolization in rheumatic heart disease and atrial fibrillation, prophylaxis after the insertion of a prosthetic heart valve, usually a mechanical heart valve, prophylaxis and treatment of venous thrombosis and pulmonary embolism, and it is used to treat antiphospholipid syndrome related thrombosis as well. It is the only one that's recommended for this. There is no evidence that any of the DOACs are effective in this indication. So that's just a run through there of the dosing, but I think we all know that it's very patient specific, depending on the INR, and depending on how rapidly the patient needs to be anticoagulated, it depends on the dosing as well. Just elderly patients can be given a lower induction dose. The maintenance dose is usually 3 to 9 milligram a day, and it is to be taken at the same time each day. So just the pros, the good points of the DOACs. So rapid onset of action. There's no loading like you would with the warfarin. Very, very rapid onset of action. No dietary restrictions, which is really helpful. Don't need to worry about the green leafy veg. Stable dosing regimens, so it's the same dose regardless of what the blood tests show or any of that kind of business. No need for frequent blood tests, and there is now a reversal agent available for dabigatran, apixaban, and rivaroxaban. For a long time, it was only available for dabigatran, so it's good news that we have the reversal agent for apixaban and rivaroxaban. So the cons of the DOACs: there's no way to monitor efficacy. There's no reliable blood test to show how well they're working. There is no licensed reversal agent for edoxaban, and as I said before, it's not appropriate in antiphospholipid syndrome or mechanical aortic valve replacement. So the pros of warfarin: you can monitor the efficacy. A very readily available and cheap reversal agent available, the vitamin K. There's years of clinical experience with its use. You do find if people have been on warfarin for years, regardless of the indication, they can be quite reluctant to change, and that's understandable. It is the only licensed treatment option in poor renal function if the creatinine clearance is less than 15 mils per minute, and it can be used in antiphospholipid syndrome or mechanical aortic valve replacement. So the cons of warfarin: requirement for frequent blood tests, dietary restrictions, variable dosing, and what I should have added there is an awful lot of drug interactions, even with medicines you buy over the counter. So other considerations: rivaroxaban 15 and 20 must be taken with food. The area under the curve of rivaroxaban 20 is 39% higher when taken with food compared with fasting conditions, indicating almost complete absorption and high oral bioavailability. It doesn't affect food doesn't affect the area under the curve of the 2.5 or the 10 milligram dose. But it is very important that patients are aware and they're told that they must take the rivaroxaban 15 and 20 with food. So if a patient comes in having had a stroke on rivaroxaban and they're on the 15 or the 20, the first question I will ask them: well, are you taking it, and are you taking it with food? So dabigatran capsules must only be dispensed in the original container or blister pack due to the potential for product breakdown, taking on moisture, and the loss of potency. So that is an issue, especially among the elderly population that need their medication blister packed, that Pradaxa capsules are not appropriate to be blister packed. So caution with duration of treatment. There's always the risk of loading doses being carried on for longer than indicated or intended. The risk of short-term indications, so what we're looking at there is the prevention of VTE after orthopedic surgery being carried on long-term inappropriately. It's the patient hasn't been told how long they need in the hospital, how long they need to be on it, and the prescription is just inadvertently repeated. So that is a risk. And if the treatment is indicated long term, so in the likes of atrial fibrillation, the dose may need to be reviewed as renal function changes, the patient gets older, or as weight changes, things like that. So interacting medicines, there's a lot of them. Antiplatelets in combination with anticoagulants can increase the risk of a bleed. Sometimes you do see it together, and sometimes there is a good indication for the two of them together, but it's just something that needs to be thought about as well and the patient counselled on. SSRIs in combination with anticoagulants can increase the risk of a bleed. Again, you do see it a lot, but again, the patient needs to be aware of it. NSAIDs in combination with anticoagulants can increase the risk of a bleed. I would say if NSAIDs can be avoided in a patient on an anticoagulant, avoid them. And warfarin has many interactions, too many for me to list, with other medications and food. So it may be prudent to increase the INR monitoring when an interacting medication is prescribed. So that's just, you probably won't be able to read that, but it's just a table that's been drawn up to go through drugs and therapeutics here to give the prescribers a bit of guidance about how to switch from one anticoagulant to another. Because it doesn't happen a huge amount, but sometimes it does happen. So it is just a bit of to make life a bit easier and a bit safer for them. So that's just something we're working on here at the moment.